Hello, I'm Jack Cush with the Baylor Research Institute. I'm going to talk to you about the management of patients who have adult onset Still's disease. It's important to distinguish patients who may have articular-only disease from those who are in the active systemic phase of the disease. So by systemic disease, I mean patients who have fever, rash, lymphadenopathy, hepatosplenomegaly, serositis, and very high SED rates in CRPs and anemia. Once all that dies down, which will happen in many patients, you may be left with a chronic arthritis. This slide shows you of the 21 patients that we followed at the University of Pittsburgh, when we looked at what happened to their arthritis over time. On the bottom, the patients who continue to have polyarticular disease, meaning they had a polyarticular onset, 14 out of the 21, and then over the next 6 months after that, the number who had a polyarticular course were the ones who went on to have more functional disability, meaning more class 2 and class 3 disabilities. So again, identifying chronic arthritis is very important because that's going to be treated very differently than the active systemic disease. This 4-panel picture shows you the patterns of Still's disease that will be seen, and that includes the monocyclic systemic onset. That's a person who has high active systemic disease at the outset that lasts anywhere from 8 months to 8 years, and then they go into remission and they stay in remission. This is a minority population, somewhere less than 15%. There are those who have polycyclic systemic, meaning they have systemic onset and maintenance of systemic active disease that goes into remission, but then recurs some 2 to 40 years later. The oldest interval, the longest interval on record is 40 years from the literature. But that can happen every few years and be active for months to years and then again go into remission. Again, this is about a third of individuals. The worrisome part are the people who have chronic disease, and they can either have chronic arthritis on top of polycyclic systemic, shown in red in the bottom left, systemic flares, and then chronic blue arthritis going forward, or they can just have the systemic onset followed by the chronic arthritis. It is that last bottom quarter panel of systemic onset and chronic arthritis that it can occur in up to 1/3 of individuals that can lead to severe disabling arthritis. So again, whether you have systemic disease or articular disease mandates the therapy you will get. On the left, you can see the systemic features that would lean more towards aggressive anti-inflammatory therapies with steroids, DMARDs, and biologics. That includes fever, rash, night sweats, even polyarthritis, but again, there's a dominance of other features: the weight loss, sore throat, serositis, organomegaly, lymphadenopathy, high liver enzymes, very, very high acute phase reactants, and a high white count. However, when that all dies down, again, there is this chronic articular phase, really just manifests as an RA-like, rheumatoid arthritis-like polyarthritis. Those patients you treat just as if they have rheumatoid arthritis. So the initial therapy in active systemic disease, when you look at and review the literature, when aspirin is used, it works about a third of the time. This is mainly from children who've had this condition. There's improvement, but it's short-lived. You have to use very, very high doses, 90 to 100 milligrams per kilogram, almost to the point of producing tinnitus in every person who takes this, and putting obviously their GI tract and kidneys at risk. Very few people use aspirin and manage this condition these days. It used to be that you would try nonsteroidals in high anti-inflammatory doses. I'm talking 150 to 225 milligrams of indomethacin a day, or 3,200 milligrams of ibuprofen in split doses. Again, that can control a lot of the features of the condition, not put them into remission, but can control the features in as much as 60% of individuals. But again, there still is a high risk of GI and renal toxicities. Hence, there is a large reliance early on in high-dose steroids. And unfortunately, low-dose steroids does not work very well. 5, 10, 20 milligrams of prednisone is usually insufficient to control active acute onset systemic disease. You will need between 60 and 80 milligrams of prednisone, often in divided doses. This works in 85% of individuals and is certainly indicated in patients who have aggressive systemic disease with multi-organs involved, patients who have very worrisome LFT elevations and hepatocellular involvement with hepatomegaly and even splenomegaly, and patients who have life-threatening complications like pericardial tamponade or severe pneumonitis requiring intubation and or respiratory support. Again, it's important to make the diagnosis early on so you can know what to do after steroids. And right now, one of the leading debates in the literature is whether or not one should use an IL-1 or an IL-6 inhibitor as a way of making a diagnosis soon after using steroids, as opposed to waiting and using a biologic only after they failed DMARD therapy and steroids. So the past approach was to use steroids or nonsteroidals to initially manage patients with this condition. Again, as they seem to have had their diagnosis confirmed, the use of either adjunctive methotrexate along with high-dose prednisone, or to go to an IL-1 inhibitor has been a more recent development. And then now I think the argument is what is going to be the role of IL-1 or IL-6 inhibitors, as these can be rapidly effective, can take patients with active systemic disease and put them into remission really quickly, and without the need for background therapy with either methotrexate or even steroids. So that we're going to need research to better define the role of those drugs in treating and defining the condition. You can see that IL-1, when it is produced in a circadian fashion. The IL-1 levels are shown in this graph, and they sort of peak early on in the evening, somewhere in the late evening, and then they go down as endogenous cortisol levels, shown here in orange, come up, which happens early in the morning. So that's why it's unusual for patients with a circadian cytokine syndrome to have a fever at 7 a.m. because the IL-1's at its lowest point, endogenous cortisol is at its highest point, and they're almost never febrile at 7 a.m. when they have Still's disease. The same can be shown here with IL-6 and its circadian distribution. You can see that the fever pattern follows the peak in IL-6, which occurs around 10 p.m. at night, 8 to 10 p.m., and then an hour or two later is the peak in fever. Again, this is often why the fevers are very high in this condition. So it is not known whether this is a predominant IL-1 or IL-6 driven disease, as both therapies seem to work. We do not have a diagnostic test, but there are a number of therapies that can be used to treat patients with active systemic disease. And these are shown for you here, along with their dosing and their relative cost. Methotrexate can be used to steroid-spare individuals and with high doses, but methotrexate is certainly very easy to administer and can be fairly cheap by comparison to the biologic agents. The biologic agents, including TNF inhibitors, the IL-1 inhibitors, can be used weekly or daily at a cost of about $20,000 a year. But again, these are now being challenged by newer IL-1 inhibitors, Anakinra, rilonacept, and Tocilizumab, shown as Ilaris, Arcalyst, and Actemra, respectively, wherein the cost can vary from $20,000 plus a year for Actemra, and if you're using Actemra in a very high dose, it can be as much as $40,000 a year. Or Ilaris and Arcalyst, where the cost is anywhere from $114,000 to $270,000 a year. So you can see, you don't want to make that jump to those new biologic therapies very lightly or very easily, especially with the cost as it is. So these drugs have been studied. We can say a few things about the use of biologic therapies designed to specifically inhibit certain cytokines. The TNF inhibitors are very effective in managing the arthritis of Still's disease. However, they are not as effective in managing the systemic phase of the disease, which seems to be an IL-1 or IL-6 driven process. So I'll show you the data that comes from the studies that show that works. Now using an IL-6 or an IL-1 inhibitor may be the way to go, and I'll show you that data as well. So this is a study that was published by Mike Weinblatt, Ellen Gravelis, and colleagues, looking at a cohort of 12 patients who have active systemic disease, not systemic disease, but arthritis from Still's disease. And you can see when they use Enbrel, 25 milligrams twice a week, that they had very good ACR 20, 50, and 70 responses. However, you notice on the right that a number of patients had to discontinue the therapy. A number of the patients continue to have active systemic features, even though their arthritis was fairly well controlled, suggesting that TNF inhibition with either etanercept, infliximab, adalimumab, etc., is probably not prudent in patients with active systemic disease and should best be reserved for those with chronic severe polyarthritis. Active systemic disease should be treated with an IL-1 inhibitor after they have failed on high-dose steroids with methotrexate. That's certainly a reasonable indication. We have 3 drugs that can be used. Kineret, the generic name is Anakinra. Also, Arcalyst and canakinumab have been shown, but I showed you the cost of those agents. These are all inhibitors of IL-1. They're all rapidly effective and really rapidly control the systemic features, the fever, the rash, the organomegaly. Those rapidly improve when they go on these drugs. Again, it's unclear whether IL-1 inhibition would be helpful in managing the arthritis of Still's disease, and that needs to be further studied. The duration of therapy is unknown because, again, Still's disease is a condition that will spontaneously remit. It will last, on average, 6 months to 8 years. I say 8 months to 8 years. No one really knows how long it's going to last. I think you should worry about the diagnosis when it lasts a few weeks or less than 3 months. Again, you should treat the patient until they have achieved clinical and chemical remission, meaning no swollen joints, no tender joints. They have a normal sed rate CRP and white count. And then when they've been in that phase, anywhere from 6 to 12 months, you can entertain the option of going off their current therapies, whether it be prednisone, methotrexate, or an IL-1 inhibitor. Interestingly, if you stop the IL-1 inhibitor, if you withdraw it, and they're on Anakinra, they will flare, usually within 3 days, certainly no more than 4 or 5 days, if they still have active systemic disease. If you're on a longer-acting IL-1 inhibitor like rilonacept, or the canakinumab, it may take many weeks before they will flare. But again, they may have active inflammatory disease that is well controlled by the therapy, and when you withdraw therapy, it'll come back. So to show you some of the benefits of these therapies, I'm going to show you how patients respond. This is the Still's disease inflammatory index, where you get 1 point each for the typical features of the condition: the fever, the rash, the sore throat, weight loss, serositis, hepatosplenomegaly with or without lymphadenopathy, inflammatory polyarthritis, high white count, high sed rate, or high liver enzymes. Again, if you have active disease, you'll have an SDII of greater than 4 points. If you're going to improve, you'll have a greater than 50% drop. If you're in remission, you'll pretty much go to 0. A flare would be a flare of greater than 2 points. Here you can see a patient of mine, BL, who's 55. He had sore throat, chest pain from pleuritis, a fever of up to 104 degrees. He lost 65 pounds of weight rapidly. He had a white count of 50,000 and a ferritin of 28,000. You can see that in orange, his SDII started out at 8. And when he went on treatment with prednisone, methotrexate, infliximab, he got somewhat better, but still had a lot of activity, being around 5 or 6. He went through a number of other therapies, and then he gets started on Anakinra. And you'll see once he goes on Anakinra, the orange line, the SDII, drops pretty much down to 0. The green line, which is his white count, which was peaking at 50,000, also drops down to the normal range with effective therapy, in this case with Anakinra. I have 3 such patients shown here, 34, 53, and 26 years of age. You can see they all had high fevers and all had high white counts and sed rates. They all were not doing well on DMARD and steroid therapy. And then when they got put on Anakinra, you can see that they've been on Anakinra from 4 to 12 months when this was done. All their fevers went away, their rash went away, swollen joints disappeared, their sed rates and white counts normalized. Their SDII went from 6 or 7 or 5 down to 0 in all cases. Again, the responses can be impressive. The same is seen with Tocilizumab. This is a published study with Tocilizumab in systemic onset JIA or SOJIA, kids with this same condition. And you can see the fever, the white count, the anemia, the acute phase reactants, the number of swollen joints, all these rapidly improve when you use Tocilizumab in the treatment of this juvenile subset of patients. If you use Anakinra, you can have injection site reactions shown here in the abdomen, or they can be more numerous, as this person who had injection site reactions in the first 26 days of treatment. Again, these don't hurt. They're sometimes a little itchy, a little scaly. They do fade away and go away within 2 weeks. but the patient's doing well at this point. As soon as they go on therapy, they do well, and after the first month, injection site reactions will resolve. Other side effects, in addition to injection site reactions, which occur in about a third of patients, it might be the occurrence of non-serious infectious events, colds, URIs, bronchitis, flu, can happen in anyone in the population, as well as patients who are taking these drugs. These drugs do seem to give a slight increased risk of serious infectious events like pneumonia. However, there is no increased risk of strange infections, opportunistic infections, or tuberculosis in patients who are taking IL-1 inhibitors, and there does not seem to be a cancer risk associated with this drug. So in the future, we're probably going to get to the point of making a biologic diagnosis of this condition and not have to rely on clinical criteria such as the Yamaguchi or Cush criteria. And what we've been doing at the Baylor Research Institute is using microarrays, looking for a signature of gene expression that tells us which patients will have IL-1 responsive disease. And I'll show you examples of that. There are other researchers which have looked at serum S100 levels, which is a very robust acute phase reactant that will go up and is found in patients with this condition more so than others. And it may well be that we have to use therapeutic intervention to define the disease as well. But again, response to IL-1 or IL-6 inhibition will be seen in patients, most patients with this condition. However, it's possible that patients with other conditions that will mimic this will also respond, as those conditions may also be driven by IL-1 or IL-6, and hence their symptoms will get better when you use that therapy. So it is still not a diagnostic test. This is the modular analysis profile done by Virginia Pasquale and colleagues at the Baylor Research Institute, where they can take a tube of blood, even as little as 200 microliters of blood, and display for you gene expression, in this case grouped into certain modules where you can have genes for plasma cells or platelets or B cells or interferon genes all expressed together in each one of these little boxes. The pattern I show you right here is the pattern of someone who has systemic onset JIA, where you can see column 2 has red dots indicating upward expression of the genes, in this case genes for inflammation and platelets and erythrocytes. The other red dots in the column 3 are for the same inflammatory set of genes, which includes, again, neutrophils, platelets, and even anemia or the development of anemia. And then column 8 are T cells being downregulated in blue. But this pattern is seen in patients who have active systemic disease, active Still's disease. And here you can see 2 patients and what happens to them. The 2 modular analyses are shown here, where on the left you can see someone who actually has the typical pattern of Still's disease, and then they receive therapy with Anakinra, and you can see that it pretty much goes away, although it doesn't go to 0, it doesn't go to normal. We're not looking at all white boxes here. On the top you can see the distance to health score, which is a genomic score for the number of abnormal genes also going down, and also the IL-1 genes going down in this one person who has active Still's disease. So this may be a useful tool in the future. So in essence, we have a way of characterizing this condition. We have now effective therapies. What's good about this is that this is a widely known condition. There are a lot of doctors who are familiar with this condition. This is often a disease that's diagnosed by pediatricians, infectious disease specialists, internists, and primary care doctors are aware of this condition and making the diagnosis often after they've excluded a cancer or a neoplasia in someone with an FUO. And many rheumatologists actually manage patients. And most rheumatologists I've met have anywhere from 1 to 5 patients in their practice and are able to manage patients with this condition. Most major medical centers will see 1 to 2 new cases per year, and it's often a grand rounds presentation or case conference as well. I think the interest, the publishing, the research has been encouraging. We're going to look at the utility of these new therapies in managing the condition and find better ways of actually diagnosing this condition in the future.